Hi and welcome to today's webinar on making sense of pain in stroke. My name's Brendon Haslam. I'm a physio who continues to work clinically but also has some faculty positions with regards to pain science and some neurological sort of work, and I'm currently doing my PhD looking at contributions to upper limb pain in stroke. The presentation is designed to go for around about sort of 50 minutes. So there should be time at the end for questions within the time allocated, so please feel free to put some through. So what I would like to look at today in going through is first of all just describing what pain is, because there's been a change in sort of terminology in the last few years. Starting to look at some features with regards to pain in stroke, some classification of pain, then discussing some potential mechanisms that have been suggested by the International Association with regards to central pain, looking at some assessment components, and then starting to get ideas with regards to development of treatment and how things are following the International Association recommendations. Just at the end, I'd just like to sort of briefly discuss some research that we're currently involved with at the Florey Institute. So first of all, if we look at the official definition of pain, and it's described as being an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Really, the key components here is this idea that it is an experience and that it has both a sensory and emotional component. So rather than it being a hardwired sensation, it is actually an experience. And it's associated with actual or potential damage. So there doesn't actually need to be tissue damage in order for people to experience pain. Another definition that has been sort of put forward by Lorimer Moseley, a prominent sort of pain scientist in Adelaide, is that pain is a multiple system output that's constructed by an individual's specific pain neurosignature. The neurosignature is constructed whenever the brain concludes the body tissues are in danger and action required. And this neurosignature includes the threatened body part. So it just builds it a little bit more. It just describes pain as being an output, something that is constructed by the brain, and for each individual pain experience, there's going to be a slightly different activation, and that this experience is basically made or constructed whenever the brain feels that the body is in danger and that it's at threat of being injured and that it needs to do something. And that this signature, this pattern of activation, will include the body part where the perceived threat is, whether it's actually involved or not. So this multiple sort of area of activation sort of is being described in terms of a pain neurosignature, or within the neuromatrix. So within the overall coding space of the brain, this idea of the neuromatrix, that there are many, many common areas that are particularly common for the experience of pain. And this has been termed this idea of a pain neurosignature. Obviously, for each pain experience, slightly different activations, but there are many common areas that do ignite all at once. This idea of a pain neurosignature or a pain sort of tag has been challenged a little bit by the fact that many, many different experiences also involve these same sort of common areas, thalamus, sensory motor cortex. And what it's now being described is actually it's more of this common representation is more that of salience, so more of importance, and we would certainly argue that makes sense that pain would sort of fit that, because pain is pretty much considered to be an important experience. A more simple way that's being utilised in teaching and a lot of clinical sort of work now is this idea that pain is the credible evidence of danger minus the credible evidence of safety. So if there is more evidence to us about the threat of danger compared to the evidence that tells us that we're safe or that our tissues are safe, that we're more biased and that we'll actually then have an experience of pain. If we consider sort of a basic pain mechanisms approach here, so this sort of concept of how the pain experience is generated. If we look first of all in red, we can see that we've got this idea of inputs coming in from the environment, both from the external environment with regards to temperature, sight, sound, touch. like that, okay, as well as our internal environment with regards to things like body position, so muscle length, joint position, as well as visceral information, internal temperature-wise, etc. Okay, important to note that we now don't put pain as this input. We much more refer to it as nociception, so that we can actually have signals of potential danger coming in, nociceptive signals, but they cannot be considered pain. The information is all brought in through the peripheral nervous system, synapses into the central nervous system through the spinal cord, is then carried up, where the brain's job then is to process and basically construct an appropriate response. So asking lots of questions of this information coming in. What is it? Where is it coming from? Is it important? What am I doing? Have I felt anything like this before? If so, what happened? All of these questions are constantly asked of this information coming in, okay, as well as the background state of potential fatigue, emotional status, so mood or feelings of unwellness, so compromised immune system, will also contribute to the actual decision that's made about all that information and the appropriate output. If, when all the information is weighed up, the decision is made that at this point of time, at this place in this point of time, a particular body part of ours is at threat of injury, an appropriate output may then be the experience of pain. So let's just step back a little bit and talk about the big picture problem of pain in Australia. And in 2001, a large study basically identified that essentially 25% of Australians have a chronic pain state. So 25%, 1 in 4 adult Australians have ongoing pain that defies tissue healing time. So they have ongoing pain past, or as a result of an injury, possibly, but that persists well past normal healing times. And safe to say, it's costing us as a community a lot of money as well, and has a big impact with regards to work, social situations. If we now look at stroke, the topic of the day, presence of chronic pain in stroke is usually reported sort of around about sort of the 45 to 50, as high as 53%. So almost double, or essentially double of the non-stroke population, the general adult population in Australia. But some of our terminology when we're referring to this lacks some consistency, and there's still lots of mentions of things like shoulder-hand syndrome and just terminology that puts us slightly apart from that's being utilised in the pain science literature around the world. Looking at the term of complex regional pain syndrome, which is a really well-studied pain state, okay, Caccio in 2009 actually found that of their large study sample, 23% of their stroke survivors actually met the criteria for complex regional pain syndrome. So having pain along with motor dysfunction, along with abnormal, potentially sweating or inflammatory sort of responses going on. So we can start to match some of our clientele with some of the pain literature that's established in other states, in other pain states. Other terminology that's used with regards to pain in stroke, central post-stroke pain, so hemiplegic shoulder pain or post-stroke shoulder pain, sort of used for some reason. Initials seem to be sort of very trendy at the moment, as well as general musculoskeletal pains and headaches. Henrietta Clitt in 2011 wrote a paper that described that people with stroke, essentially 40%, sort of, almost 40% of people with stroke went on to develop new pains post-stroke as well. And rather than the indication being whereabouts they had the stroke, actually the most common association was with people having strokes at younger ages, or that with states of comorbid depression. So clearly there is more to it than just a lesion in a particular area. Again, descriptions of these sorts of pains, headache pain, shoulder pain, muscle stiffness, joint pain, nothing too sort of really different there. But this presence of new pain, at 40%, didn't include those with pain that came in that had pain prior to their stroke. So we also need to consider that 25% of people coming into stroke already have a chronic pain state. These new pains, as we would expect, more often than not unilateral. So the impact of pain is fairly significant generally, but in particular with people with stroke. And it's been described in terms of physical functioning, emotional, sleep, role and social functioning and quality of life. The biggest impact with regards to physical functioning has been described as being that of mobility. Not surprisingly, the higher the pain, the higher the impact on mobility. So here we've got a population whose mobility is already compromised, that is further compromised by this presence of pain. Again, with emotional functioning, high correlations with increasing rates of anxiety and depression. Sleep is often not reported in a lot of these studies, and the Jensen study that's listed below is a really large review of a huge number of studies, I think 52 studies, and hardly any of them mention sleep, which is a real shame, because poor sleep patterns are commonly associated with ongoing sort of this persistent neuropathic pain. Impact of pain on role and social functioning, global quality of life. The higher the pain, the lower the quality of life, the lower rates of return to work, social interaction, community sort of work as well. So now let's look specifically at central post-stroke pain. Certainly when I started, it was called thalamic syndrome or thalamic pain. That's a term that's not used so much. We're now much more going to central post-stroke pain. But we still haven't clearly defined it. And there's lots of descriptions that are out there. Commonly described as along the lines of what I've written sort of there, that it's a central neuropathic syndrome followed by a stroke or a CVA that's characterised by both pain and sensory abnormalities, attributed to that by a part of the body that correspond to the lesion, where there's no obvious nociceptive, psychogenic or peripheral neurogenic origin for the pain. So basically, it's an experience of pain with sensory abnormalities in that sort of area that can't be described by any other cause. It's characterised by either constant or intermittent. It's both with these people in an area where there's sensory abnormalities after a stroke. As we've discussed, abnormalities in sensitivity to temperature and on specific pain threshold tests as well, we get abnormalities. But there's no specific pain feature that's listed for central post-stroke pain. There's a range of descriptions that are used. Some will describe burning, some will describe stabbing, some will describe prickling, or raw, or itchy, or superficial, or deep. Lots of these different sorts of words come about, but there's not one that's specific that's common for people just with central post-stroke pain. So we don't have also a uniform sign that indicates the origin of the pain. Remembering again that a significant amount of people prior to having a stroke will have a history of chronic pain. So in some ways their system's almost primed. Okay, and they will often go on to develop other pains as well, as discussed in the CLIT study. The distribution, again, most frequently reported in the hemi body, and I cannot stress enough, it's always located within that area of abnormal sensitivity. But if it was purely hardwired, then we would expect that this onset of the pain experience came on automatically. It comes on pretty soon, straight after the stroke, and yet that's not the most common sort of thing. Most common is this gradual onset, with the development of pain being described as between the first 3 to 6 months. So it suggests that maybe there's a little bit more at play here than a particular lesion being directly responsible for the pain experienced. Number of aggravators that have been described in sort of literature, and that for some people movement will aggravate, cold, light touch, warmth, high states of emotion or stress. Orgasm has also been described. But again, this inconsistency, because there's also reports by some people that some of these things actually are used to help to decrease pain, and a lot of people report that warmth actually helps them, and some people will find that warmth aggravates it. So we don't have these clear findings that are there. Again, we come back to this idea of that we will have pain when the credible evidence of danger is higher than the available credible evidence of safety. So when we feel at risk. Going into these clinical findings, we've discussed that central post-stroke pain patients show sensory abnormality when it's examined. Okay, and this can be across the board, okay, or just one or two components. Certainly tactile deficits, thermal deficits, really, really common. Pinprick deficits, two-point discrimination. Interestingly, proprioception seems to be the one that has the least strongest link with regards to this sort of presence of central post-stroke pain. If we go into findings a little bit more, looking at dysesthesia or allodynia, and they're frequent findings that contribute. So what we're actually finding is that nearly 3/4 of people with central post-stroke pain in the literature are described as also having allodynia. So this idea that people are experiencing pain to a stimulus that would not normally be described as painful. Okay, so for some people that might be light touch. Okay, that light touch may now be associated with being painful. And this idea of mechanical allodynia, sort of to touch or to movement, is more common than thermal allodynia, this idea of being extremely sensitive to temperatures. Okay. If we start to look outside of the sensory sort of findings, the findings aren't as universal, okay? And certainly, as we'd expect, okay, we are going to commonly find other neurological findings. The most frequent that's there after the sensory sort of stuff is ataxia and then paresis. There doesn't seem to be strong links with regards to the significance of paresis and the presence of pain. Looking at sort of things from a quantitative sensory testing, we do find changes with regards to tactile stimulus, cold and warmth, okay? But these don't necessarily, the degree of these don't correlate with the degree of pain, okay? Certainly we find changes in thresholds. But again, also, and this starts to make sense, there's significant discrepancies between clinical examination and the quantitative sensory testing results, okay? And if we think about that in the next sort of picture, which I will bring up now, oops, no, I thought I had a different picture. If we think about that makes sense, because the environment is going to be constantly changing, so people are going to be in more stressful situations at other times and more sensitive and more sort of on alert. There are so many different factors towards this pain experience other than pure hardwired sensory information. So in conclusion on central post-stroke pain, we're starting to see with this gradual onset that we can maybe start to consider that it's starting to occur independently of injury, that maybe it's not the injury that hardwires it and makes it an absolute for these people experiencing pain, that there are a number of other findings and a number of different contributions and certainly significant sensory sort of things. And investigations via CT and MRI have certainly shown that having lesions involved in the spinothalamic pathway, the thalamus or the projections, while they can certainly contribute to central post-stroke pain, they're not sufficient to cause it themselves. Okay, so having a particular lesion somewhere does not hardwire them to absolutely experiencing pain, and there are a number of people that will have lesions in exactly the same thing that may or may not have pain. So we don't have this consistent pathway, but this consistent sort of a thing. But certainly these lesions can contribute. In looking at central post-stroke pain, we also need to consider that it actually only accounts for around about 8% of stroke survivors with pain. So we now need to consider, well, let's have a look at hemiplegic shoulder pain, which is the most common pain that is experienced post-stroke. Let's look into that a little bit more. So post-stroke shoulder pain, which is sort of, again, they like their abbreviations, okay, around about 40% of people. Typically regarded as being nociceptive pain. Historically, we've tended to focus more with regards to the idea of this pain is of nociceptive origin, is from a tissue damage perspective. And yet, treatments that have been aimed at reducing this nociception have produced far less than satisfactory results. Okay, and now starting to look at this post-stroke shoulder pain a little bit more. When now actually there are studies that are showing that actually there's signs of this central sensitization, which I'll talk about in a sec. So there are signs of changes to the sensory perception and the processing of this sort of information. So again, things like allodynia, where stimulus that would normally not cause pain is now being perceived as threatening and producing pain. So again, light touch, various movements can bring on these pain responses. Okay? And I think what's really pleasing from a research perspective is that there's a lot of overlap that's being shown between post-stroke shoulder pain and central post-stroke pain, that it's harder to define between the two because there is so much overlap going on. Certainly with these post-stroke shoulder pains, we do find that the sensory discrimination is reduced in that same sort of area and indicative of somatosensory processing being altered as well. So very briefly, looking at the classification of pain. So just stepping back a little bit for a sec. Pain is traditionally classified into either that of nociceptive pain or neuropathic pain. Nociceptive pain, as defined in 2011, is pain that arises from actual or threatened damage to non-neural tissue and has contribution from nociceptives. Again, this idea that there can be actual tissue damage or even the threat to tissue damage, okay, is enough to cause a pain experience or to send these damage signals, these signals of danger up to the brain and then possibly contribute to a pain experience. Interestingly, this definition is relatively new. It's not that long ago that there weren't definitions for nociceptive pain. What the definition has come through now as it's been developed is basically to distinguish it as something different from neuropathic pain. So whereas before all pain was considered to be sort of roughly the same, we're now distinguishing, there is a distinction between that of nociceptive and that when there is damage to the neural tissue. So neuropathic pain is now defined as being pain that's caused by a lesion or disease of the somatosensory nervous system. It was designed initially to be a clinical description rather than necessarily to be used as a hard diagnosis, but what it does, it is commonly utilised now with regards to research and literature as a diagnostic sort of situation. Important to know that neuropathic pain can be either central or peripheral, and in the general population, peripheral neuropathic pain is far more prevalent than central neuropathic pain. Nothing new to this group here, the idea that somatosensory refers to information about the body rather than that of the external world. But in looking at this and the common descriptors that are looked at with regards to neuropathic pain, I've sort of touched on things like allodynia or burning or something like that. There are a lot of people out there that also report these same sort of symptoms that are easily described as having neuropathic pain, yet who don't have any sign of neurological injury. They don't have. There's no lesion. There's no disease. So there's a lot of people out there in the non-neurological sort of population who are being incorrectly diagnosed as having neuropathic pain without actually having any damage to the nervous system. And it's because it gets a bit confusing. So many people, as I said, will present with these symptoms that are described but actually fail to meet the criteria. Similarly, many people with neurological injury may actually have pain that is more from a nociceptive contribution rather than a neuropathic contribution. So we need to be sort of quite aware of what contributions are going on for that person's pain state. So if we're thinking about what is post-stroke shoulder pain, is it nociceptive or is it neuropathic? Is it nociceptive, in which case we would expect it to be sort of far more tissue damage approach, okay, with ongoing injury, okay, and we would expect a better response to interventions that are aimed at this nociceptive sort of thing, more structural approaches. Or is it neuropathic? Is it there in response to the neurological lesion? Then in which case we would expect that this sort of shoulder pain would be much more, the onset would actually be much sooner post-stroke rather than, again, like central post-stroke pain, this gradual onset over a period of weeks and months. So neither of them really give us a good answer. So a new term that's being bandied around and being introduced by Phil Siddle from Sydney, who is the Australian representative for the International Association of the study of pain with regards to neuropathic neuropathic pain, and one that's involved in various sort of statements from this group, it has started to put this term forward about neuroplastic pain, which is really looking to describe that actually this pain output system is far more complex than a simple straight tissue injury or a straight lesion to a particular area. Okay, that it is far more plastic, so it's constantly changing and it's able to be influenced. And it's recognising, as I said, these ideas that the system is plastic and that changes are continually taking place, both out in the periphery but in the spinal cord and in the brain itself. So mechanisms that have been described, and I think it's important to think of this sort of neuropathic versus neuroplastic versus nociceptive sort of point. So mechanisms that have been described by this Neuropathic Pain Special Interest Group of the International Association, based on the idea that pain is an output, so that it is the information coming in from the periphery, okay, internal and external environmental information processed up through the central nervous system to make a decision, okay, and if that decision is that currently part of our body is under threat, okay, under potential threat of tissue damage, that the production of pain as an experience has a protective role, then pain will be produced. So the potential mechanisms that have been described, and these were described for central post-stroke pain, but now with the overlap that's going on, I think we can start to think a little bit more broadly with regards to that. And these three fundamental mechanisms have been sort of discussed. The first being disinhibition, then sensitization, and then finally plasticity. So in disinhibition, we're really looking at a state where this mass activity is released due to a loss of normal inhibitory control, okay? And that can be either from local or distant systems, okay? And this really helps. So basically there's a really reduced inhibition, very, very easily to get mass activation, activate this idea of high salience within the neuromatrix and activate areas commonly associated with a pain experience. And this idea of disinhibition helps to explain some of this sort of sensory phenomena that people with pain describe immediately or within a short time following the stroke. So those people that within the first few days are describing burning or prickling or constant pins and needles and all of that sort of stuff are more likely to be, I guess, explained by this idea of disinhibition immediately following the stroke. The next stage, that's the next mechanism that's been described, is this idea of sensitization, and predominantly central sensitization. So where we have got, again, this mass activity of activation occurring because of an increase in responsiveness to normal inputs. So the information is still coming in from the periphery, okay, but that it is amplified as it comes into the central nervous system. Okay. So there's at various points, and we will discuss this idea within central sensitization, how there is amplification of signal. The higher the volume of the signal, the greater threat value, the more likely for it to be then considered to be at risk of tissue damage and the experience of pain. There's also suggestions with regards to this, there being a possible increase in background activity, that the resting states are a little bit sort of higher. I think we can also consider that in some ways this has a component of disinhibition from the earlier slide. And certainly within centrally sensitized states, we are getting biochemical changes. So the neurotransmitters that are released have an increased potency. There's greater efficacy of the receptors that are there and changes in the intracellular sort of level as well. With sensitization, with pain that's attributed to this idea of sensitization, it doesn't occur immediately, okay? There are changes that occur, but this is more likely to develop over a period of weeks. And this starts to fit with the model of common sort of onset of pain post-stroke, is this sort of gradual increase over a period of time. If we consider, and this is a diagram that's sort of as an example from the dorsal horn, in the spinal cord, this idea of stimulus coming in from the left along the C fibre, there is release of neurotransmitter, the the little dots in there, okay, there's potential influence from excitatory neurotransmitters, so substance P, glutamate, and inhibitories with being GABA from other sort of areas. But in a normal resting state, the influence of these others isn't that much. So stimulus along the message is carried along the C fibre, release of neurotransmitter into the synapse, and they will then normally sort of go through the natural killer sort of cells, the natural killer receptors or ion channels and the AMPA ones. The NMDA channel will stay closed, and then that transmission is then carried up through the wide dynamic neuron. So this is pretty much at a resting state of a normal sort of system that is going on. Important to note that this is able to be influenced, okay, and if people are engaged in meaningful activity, sometimes we would start to perceive that some of this other information with regards to things may not be as important. So what we are able to do is, with a signal still coming in along this C fibre on the left, is that if we look up at the inhibitory neuron, that we are able to increase the production and increase the release of particularly GABA, which acts to suppress the volume. So it actually influences the release of neurotransmitter, but most importantly, the uptake of the neurotransmitter in this blue wide dynamic range neuron, so that the information coming in from the C fibre is now, as it's transmitted up the wide dynamic range, the volume of the message is much, much less. So then threat value is much less. This signal is not given as much importance, and less likely to contribute to an experience of pain because other signals are more important at that particular time. When this idea of ongoing pain or sensitization, though, is that there starts to become more attention to these areas. So as you can see from this, it starts to get a lot more confusing. We start to, at the presynaptic sort of level, get more gates, more release of potential more release of neurotransmitter. We have increased excitatory components. With more attention to this area, more sort of questions and not understanding the area so much, the brain then has an effect to reduce from the top. If we look at this blue one at the top, we actually have reduced inhibitory effects. So the production of GABA is not as much. And that fits with also people not being as engaged in meaningful activity. So we have got, coming in from the left, we've still got the same sort of signal. There is a slightly enhanced release of neurotransmitter here. We have little inhibitory effect coming from the higher centres, okay? But on the wide dynamic range neuron, we can see that also there are a number of additional ion channel sort of gates that have been laid there, so that there are more potential for some of this neurotransmitter to be taken up by the wide dynamic range neuron, and we get a stronger signal. What also happens is, sorry, this one just moved across a little bit, is that if we now also look at here where the blue circle is, because in a sensitized state, the NMDA channel starts to open. And the difference with this NMDA channel is that when it's open, it actually stays open for much, much longer. So we get a rapid change in polarity. And this calcium channel, the increase in calcium suddenly comes through much, much stronger. So again, much bigger signal. Also, what becomes involved is that, as well as the neuronal sort of system, is that the immune system comes into play as well, and we get increased activity of microglia and astrocytes that will further influence. Looking more specifically, traditionally with regards to nociceptors, the C fibres will come into laminas 1, 2 and 5, while the A beta fibres will come into 3, 4 and 5. In this more sensitized state, if we look, the C fibre, there's actually dieback from lamina 2. It actually more goes into lamina 1. But interestingly, these A beta fibres, it's got in this diagram that it actually sort of grows into lamina 2. Just in the last few months, the thinking of that has actually changed, and what they're now saying is that there's actually increased excitatory neurons as well. So that there's an increase in activation in this sort of first and second lamina due to activation of these excitatory interneurons. So going on from sensitization to more neuroplasticity, okay, we all know what neuroplasticity is. It's this normal activity that occurs because of a change, and it drives organisational change, okay, both anatomically and functionally, and it's this ongoing sort of sprouting, okay. But what can happen is that this sprouting can also produce abnormal connections, and that has also been sort of put forward as a contribution to this sort of ongoing pain. So we get an imbalance in modulation, so we get changes in network activity. But, as we know, this neuroplasticity is normal, okay, and it's how we adapt to different environmental conditions. Unfortunately, in pain states, this neuroplasticity can occur to basically almost enhance the sensitivity of things and enhance the efficiency of pain production. So plasticity involves learning new tasks, incorporating new experiences, and with a pain state, these tasks unfortunately aren't sort of increases in function, but actually start to become due to more protective behaviour and lack of use. So this starts to now become the more normal sort of state. And these sort of plasticity changes, these changes in organisation, are more sort of associated with these symptoms of pain occurring over sort of more weeks, months, years. Looking at sort of these maladaptive plastic changes. What we are continually looking to do is to remap sort of the cortical representation to have as a refined, as efficient, as organised a system as we can, and as good a body ownership as we possibly can, in order that we can have the most understanding about the information that's coming in, therefore less likely to be threatened, less likely to have pain. So what can we look at from an assessment point of view? Certainly, we don't want to count out these ideas of normal range of movement assessments, okay, mobility, all of those sorts of things, palpation skills, but we need to go a little bit sort of further than that. The best thing, obviously, is going to be a good subjective assessment, actually finding out what activities or what brings on the pain. Try and work out when are these sort of danger situations, when are these high threat situations more common and associated with pain. But also, what are the things that are going on with regards to when they're more comfortable? What's the information that we can get from that? And what activities are they involved in? What are their meaningful sort of things? Their social network, psychological support, all of these sorts of things, remembering that pain is a sensory and emotional experience. So all of these things will contribute. There are some outcome measures that we can use. In research, particularly in Europe, this idea of QST is being increasingly used to develop this sort of mechanism-based approach, as well as looking at motor and functional performance. So going in a little bit more detail, the assessments that are there, a simple visual analog scale can be useful. It tends to be a little bit unreliable, though, when we're looking at people who may describe a mix of symptoms. So they may describe burning and they may describe prickling. They may have a reduction of one, but not a reduction of the other. So this visual analog scale for pain overall in this group is a little bit less reliable. It's good to get the sensory mapping to get a good understanding and sensory assessment of the areas that are going through, okay, as well as looking at temperature abilities. QST, as I said, is increasingly used in research in the European groups. Use of disability in motor scales, I've put a little question mark here with regards to it, given that I don't believe they're sensitive to change or sensitive to being able to detect differences due to pain or due to neurological disability as well. There is a wheelchair user's shoulder pain index that's utilised more for people with spinal cord injury. McGill pain is very useful. the ones that in green here that are used more in identifying potential contributions to neuropathic pain are the Leeds assessment of neuropathic pain, of neuropathic signs and symptoms, and the Delore neuropathic 4. They're more to identify if there are potential neuropathic contributions and not particularly sensitive to change. The ones that are sensitive to change that we can get measures on are these ones in red, of which the two that are most commonly used are the neuropathic pain scale, which has unfortunately just gone black, and the neuropathic pain symptom inventory. They utilise measures sort of scale 0 to 10 on these particular descriptors, so we can start to get behaviour and scores on some of these different pain experiences as they describe, and then see which can be influenced. So these assessments are obviously going to be useful for reporting, reassessment and research, but they can also start to give us information and ways into the system that we may potentially be able to identify treatment strategies. And this is now being used in research. So someone describing that their pain is sort of more superficial, it may be more appropriate to utilise more interventions looking at sort of deep stuff to start with, deep contact, so that it doesn't aggravate the pain state, and then be able to sort of establish a better rapport before going more superficially. So what's currently happening? What we have got is this predominantly medical model, unfortunately, still in the management of stroke patients, okay? It is very heavily medicated bias, but we do have an increasing sort of look to establishing clinical guidelines, and there is some research that's going on, so let's quickly go there. Medication, what's currently happening are these targeted medications, traditionally anticonvulsants and antidepressants, but they have unfortunately quite poor effectiveness, so poor numbers needed to treat, and they are associated with side effects. Rehabilitation strategies that traditionally have targeted pain as from a peripheral nociception perspective have not produced very satisfactory results. As I've mentioned, medications that are used commonly are these top two: anticonvulsants, antidepressants are your front line. If we quickly look here at these numbers needed to treat and look at this sort of central line here, the central pain and general neuropathic pain numbers, we can see that there are a number of areas that we don't have data on for some of these medications, okay? But if we look at the tricyclic antidepressants for central pain, the number needed to treat is 4. So what this is saying is that for every 4 people to receive this medication, one person will get a reduction in pain benefit of 50%. So we need 4 people for one person to get a significant treatment effect. These numbers are actually quite generous. They're about to be changed as more robust studies have come through. These numbers are actually increasing, and the new guidelines have just changed to reflect that. So these numbers will very soon be out of date. The anticonvulsants, pregabalin, gabapentin, number needed to treat of 5. As I mentioned, these medications do have significant side effects, so some people will have difficulty taking them, and if we look at the effects, they're very, very significant, okay, and quite debilitating. We need to be aware of, is the effect of medication causing this, or is it actually part of the neurological deficit itself? So it starts to get really tricky, and we need to be very mindful when introducing these medications due to the nature of possible side effects they could get. Antidepressants, again, still with dizziness, drowsiness, sedentary effects. So when people have looked at studies that have been done in pain in neurological conditions, they've pretty much always done them with regards to the effect of this medication of pain in stroke or in multiple sclerosis or in Parkinson's. And the numbers needed to treat have been very, very poor or no significant effect at all. So the questions now, are we better off going by the symptoms? So medication studies are now being performed based on their sensory profile. So looking at the pain experience, looking at this description of burning or prickling or things like that, as well as actually looking at the straight sensory abilities, so the people's ability to detect, to discriminate changes in sensory sort of stimulus. And these are starting to get some really promising results. So what we are finding, what's certainly being reported in the Daniel et al. Stuff, is showing that basically the smaller the sensory deficit, the more effective that medication is, and this has been found particularly in Botox and pregabalin as well. So the groups they're looking at are these burning and prickling, these spontaneous attacks with little other sensory sort of stuff, numbness and melodynia, and these painful attacks with pressure-induced pain, and starting to look that perhaps medications may be more effective for one particular group than for another. So the etiology, the actual diagnosis of the neurological condition doesn't indicate the symptoms of neuropathic pain, okay? Many different neurological conditions report the same range of symptoms as do stroke. So now the studies are going more to look at, instead of looking for a particular diagnosis, a particular etiology, more looking at this sort of profiling of pain description and giving an insight with regards to this being targeted therapies. So that hopefully we'll start to see these numbers start to change. There are invasive interventions that are out there. I'm not able to talk about those today. But if we do look at rehabilitation, okay, if we look at the current guidelines that obviously are undertaking sort of a bit of a change at the moment, those guidelines for shoulder pain highlight we should be looking for those that are at risk potentially of developing pain due to weakness, and that strapping or education to prevent trauma may be helpful. For those that already have shoulder pain, we should be basically treating it potentially like a musculoskeletal pain, even though we now know there's significant differences with regards to that from a somatosensory perspective, and that steroid injections and ultrasound aren't any help. For those with central post-stroke pain, we should be trialling medications, and if that's not working, refer to a specialist management team. For those people that work in pain units, the average waiting time for an assessment for suitability for a pain management sort of program is between sort of 6 and 8 months here in Victoria. So if we look at the effect of that and these changes of sensitisation and plasticity, that's really not going to help us. We need to be targeting things much, much sooner. So the current review that we've just sort of doing at the moment has looked at the evidence with regards to taping and strapping, positioning, electrical stimulation, use of imagery and psychological musculoskeletal strategies. Really very, very little evidence. There is, as we've mentioned, evidence with regards to that taping or strapping may help in reducing people going on to develop shoulder pain. There's mixed evidence from positioning and stretching, from no effect to actually some negative effect. Electrical stimulation, there are a couple of studies that show some effect, but this is from implanted stimulation, and we don't have studies with regards to use of imagery-based or psychological strategies and general musculoskeletal strategies. We just don't have the data there. So in looking to develop treatments, we need to start to shift away from this anatomical structural approach and more towards treatments that demand changes in processing and demand new outputs. Okay, we need to identify that people with ongoing pain experience pain to lesser stimulus than previously. Okay, but that threat level, that pain threshold, is now not reflective of potential damage to tissue. We need to be able to educate these people that although they are sore, they are still safe from injury, and that we should be encouraging them to be able to do more and reduce the threat, give them power to be able to do extra sorts of things with the understanding that they are sore but safe. The Neuropathic Special Interest Group have recommended that we should be looking at networks of centres that deal with stroke pain, and studies should include sensory dysfunction, and we should be looking at sensory rehabilitation. Studies to do that combined with imaging, and we should be really building networks of clinicians and scientists, which is what we're trying to do. So the current study that we're doing, okay, I just want to outline two that we're involved with at the Florey Institute. There is a study called Connect and a study called Recognise. The Connect study is a study of people with upper limb sensory deficits, okay, that undertake a very structured sensory retraining program and we've got a number of outcome measures looking at mood, impact of stroke, as well as some pain measures, a battery of sensory stuff, and these body laterality, which I'll talk about in just a sec, complemented by functional MRIs. And the research that we're also looking at is this one called Recognise, which is done entirely online. It's anonymous, and it's a series of questionnaires that we've developed, as well as use of standardised ones such as the neuropathic pain symptom inventory. So that's designed to actually match some of these medication studies that are going on in Europe to look at this profiling effect, as well as people's beliefs and perceptions in pain. And then a couple of interactive tasks that are based on our knowledge from other conditions. So other conditions of long-standing pain states, so something like complex regional pain syndrome or long-standing neck pain, is that we now know that people with these long-standing pains, that when they're presented with images, so if someone has long-standing right hand pain, if they're presented with images of left and right hands, when they're asked to identify which is which, they're very quick and accurate at identifying the left hand, but the affected hand that they have the pain condition for is that they take longer to make a decision about that being a right hand, and also they're more likely to get it wrong. And this has been useful in developing treatments that have been shown to be effective in things like complex regional pain syndrome. So the interactive tasks that we'll have people do as part of this study is just a simple choice reaction task between left and right arrows. We'll then present them with a series of images of shoulders to get information about their abilities from that, a series of images of hands, and then finally, because we will be rotating the images a little bit during the testing procedure, which again is all done online, people can do it at home, and we've introduced an object rotational task as well. People that have sort of helped us come on board, we've certainly got some great networks within Australia. People like Lorimer Mosley and David Butler, both from South Australia, that are fantastic pain researchers and pain educators, as well as in communication with people in the UK that are combining some of these things, and in Germany as well. As I said, we've designed it to match some of these medication studies looking at profiling. We'll also be able to get information from that study to then identify potential education needs, so that there's scope for an educational program to be developed for people with pain in stroke, which has been shown to be incredibly effective for other pain groups. So that's pretty much where we're at. I appreciate we've rushed there. There is so much more that we can talk about with regards to pain, this idea of the role of the immune system, spatial perception, use of vision, more information with regards to sensitisation, as well as, things that people have got a good understanding with. How can, things like environmental enrichment, learning strategies, engaging in meaningful activities, activating dopamine and increasing production of GABA to help in this inhibitory modulation. So much more. So thank you. I would like to acknowledge Professor Leanne Carey at the Florey, who is also associated with the La Trobe and the University of Melbourne, along with David Butler, who is part of the Neuroorthopaedic Institute, who's actually hosting the platform for our research, and Lorimer Mosley and Halton Stewart for helping us get things together. Finally, if people are able to help us, this is a shameless plea. We are after for a lot of people to participate, both with and without stroke. They can go online at home. It doesn't matter if they have pain or not. There's the link there. Please go on and spread the word for as many people as we can. We want numbers of around about sort of 1,000 in each group. So we're after the big guns. Okay, thank you very much. If there's any questions, I'm happy to answer any.
Thank you. I can see a few people typing, so we'll wait a few moments to see if any questions come through.
Sure, no worries.
We'll just give it a few more moments. Okay, Brendon, there's a question from Diksha.
Okay, shall I read it out? So the question is, could you please clarify regarding your treatment strategy for superficial pain? Could you please clarify what a deep pain treatment would look like practically without aggravating superficial pain? Really, with regards to that, if people are identifying that they're describing their superficial pain, which means that their pain is superficial, and more likely to have pain with regards to light touch or anything else like that, one of the things that we look to do is that we basically want to start to get people to be able to accept touch. But if we just provide that touch stimulus to start with at a light touch sort of perspective, that is instantly going to be threatening and aggravate the situation. What we'd be looking at is really getting people to look at the affected body part, potentially get them to touch it with deep pressure, and that maybe us as therapists could introduce our hands onto that sort of area at the same time with regards to pressure, and then potentially start to actually get them accepting us providing this sort of slightly firmer contact in a way that they've already seen and experienced and know that is safe, and then get them more and more used to this repeated sort of touching while looking at it, and then progressively be able to get it lighter and lighter stimulus so that ultimately they're more comfortable tolerating that sort of stuff, with regards to potentially even looking at different fabrics and light touch and stuff like that. So it's really how do we look to try and break down the barriers, and if people are giving us definite sort of alarm bell warning signs on something like this sort of superficial pain or allodynia, ultimately we want to be able to make a change. We want to be able to get in there and get these people tolerating sensory stimulus. We need to be able to do that in as less threatening a way as possible. I've just seen two questions come in. Just wondering whether the Connect study is still running. Absolutely. We've just increased our recruitment for another 9 participants. So certainly we've got scope for that. We've recruited 36 now. We're hoping to get 45 for those numbers. So yes, and if people want to contact me with regards to that, I can sort of put people in the directions of where we need to go. There is another question. If I could give a piece of advice to physios working with stroke to minimise the likelihood of pain, is there anything I would advise? So really this is the early sort of stages. One of the things, I think the big thing that we first need to be able to do is to make these people feel safe. Unfortunately, in the early days, we tend to give people a lot of advice with regards to that their shoulder is really fragile and that everyone needs to, and we all should almost wrap it up in cotton wool and watch out for people. Don't let anyone touch you this way, don't let anyone touch you in this way, and just be careful of it. And that instantly sets up a thinking as if I'm damaged and I'm at risk. One of the things, certainly we want them to be comfortable, but we do want to encourage regular inputs with regards to that person's arm and their ability to look at it and see that it is doing things and seeing that it is able to do this, or that other people are able to assist it in movement. We need to really look to reduce the threat value, and unfortunately a lot of the information that we give people is more about the need to protect, which ultimately builds a threat state. Are there any other questions at all? A question here, the research stroke with regards to the laterality is open to all people without stroke. Absolutely. We want people without stroke to be able to do it and be able to make comparisons. We want people without stroke that don't have pain. We want people that have got pain. What we're ultimately looking to be able to do is to make comparisons between a pain-free non-stroke population, a population without stroke that do have upper limb pain, as well as stroke populations with upper limb pain and without upper limb pain. So we can really, which is why we're going for the big numbers, to really get the robustness and make some fantastic comparisons. And ideally also be able to make those comparisons along the lines of those symptomatic sensory profiles that are being used in the medication studies as well. The questionnaire is taking around about, for people without stroke, it's taking around about 15 minutes. For those with stroke, it tends to take about sort of between 20 and 25 minutes. They are able to take rest breaks along the way, simply because there's a few more questionnaires that that people with stroke and those with pain will need to be able to do. So it does take a little while, but we've needed to sort of do that to be able to get the quality of the information that we want. There's another question with regards to how does midline perception affect pain. This is a fascinating thing. I'm just going to very quickly quote a complex regional pain syndrome study that was done, where they looked at the effect of crossing the midline, so actually putting the right hand into the personal space of the left hand and the left hand into the personal space of the right hand. What they actually found with this population with complex regional pain syndrome is that had temperature changes and had various testings with regards to stimulus, is that when they moved that hand into the personal space of the non-symptomatic hand, is that the temperature change actually moved towards that of the non-sympathetic side, and that the point at which pain was experienced to these stimulus actually also came on a little bit later, more towards the line of the other side. What was also fascinating was that by moving the non-affected side into the space of the affected side, that there was also a shift in this sensitivity and temperature towards that of the symptomatic side, I should say. So this idea of moving into the personal space of the other one seems to have quite a significance with regards to body ownership. We now know that the limbs don't actually need to be crossed to go into those positions, that actually if we just move, say it's the right hand, into the space of the left hand and move the left hand over a little bit more, we get a similar sort of effect. So there's some really fascinating stuff with regards to personal space and body ownership as well.
Thank you. There are no further questions at this time. So back to you, Brendon, for closing remarks.
Okay. All done. Thank you so much. As I said, if there are any questions, please feel free. My email is there. I'm happy to sort of take queries sort of later on. And if you're able to spread the word about research that we're doing, that would be fantastic. We're recruiting through until the end of this year. So we've got ethics approval to recruit through a number of resources and through social media and everything as well. What we just need to be aware of is that we can't recruit through hospitals because they need to have individual ethics clearance for each hospital. So we haven't done that, but certainly within private clinics and community clinics and generally things like that, and stroke support groups, that certainly we've got ethics approval for all of those and general communication. If that's all, thank you very much, and I look forward to meeting you all at some stage as we go along. Cheers, bye-bye.